Good evening, everyone. Warm welcome to Masterclasses in Critical Care Medicine from Yashoda Hospitals, Hyderabad, in association with ISCCM Hyderabad chapter. Today's topic case discussion is Subarachnoid hemorrhage. We have senior examiners, Dr. Rajesh Kumar Pandey, Senior Director, HOD, Critical Care Medicine, BLK Max Hospitals, Delhi. Welcome, sir. And another examiner, Dr. Raymond Dominic Savio. He is lead consultant, Apollo Proton Cancer Center, Chennai. And case will be presented by Dr. Uday Kiran, and Dr. Shilpa will help him. Dr. Uday Kiran, you can start the case.
Yes.
Dr. Uday, please close the presentation and reshare it.
Yes, sir. Yes, sir. Open and large open.
Please reshare it again, sir.
Yes.
Yes, sir. Good to start.
Yes, sir. Good evening. Today's case presentation is subarachnoid hemorrhage, and 41-year-old female presented with seizure-like activities at around 10 a.m. lasting for 10 minutes at home, and it is associated with stiffening of hands and frothing from the mouth. And then went to local hospital, and in local hospital there she had another episode of seizure activity, and then treated with phenytoin and diazepam, and then came to our hospital for further management. And the history of seizure disorder for this patient, and she is not on any medication, and no history of head trauma, ENT bleed, or vomitings, or fevers. Coming to Cns examination, patient is in post-ictal state, and the initial GCS was A1 V1 M3, tuberous, not following commands, and when on painful stimulus, there is when compared with left side, right side weakness was noticed, and CVS was S1 S2 heard, and no murmurs, and in respiratory system no added sounds, and GIT soft and tender, non-tender, and no organomegaly. And initial vitals were blood pressure was 100/70 mmHg, and heart rate was 120 beats per minute, and SpO2 of 96% and 8 liters of face mass. And initial respiratory rate is 20 breaths per minute, and GCS is post-ictal state, not following commands, and E1 V1 M3. And the pupils were equal size and reacting to light, 2 mm, and initial temperature was 99 degree Fahrenheit. And we have done ABG. ABG is showing with a pH of 7.35 and PO2 of 88 with 8 liters of face mass. And initial lactates were raised secondary to seizure activity, and that is 4.6, and initial sugars were 190 per deciliter. And then
okay, Uday, maybe we can just stop there before moving on to the MRA and all that. So can we just take it stepwise? Let's go to the first slide.
Yes, sir.
Okay, just go back to the first slide.
Yes, sir. Yes, sir.
So here we have a middle-aged lady who seems to be a known seizure disorder presenting. Let's say, of course, she went to an outside hospital. Let's say if she had come to you,
Yes, sir.
just describe your goals of care, what you would do, 1, 2, 3, you know.
Uh, uh, for any patient in initial emergency room, we have to airway breathing circulation is a priority for all the patients, and we have to secure the airway. Initial GCS was less than 8, and BP was maintaining. We have started with fluid therapy, and next circulate.
Why do you want to intubate everyone who has a less than GCS 8?
In poor GCS patients, they don't have protective reflexes
Yeah.
to prevent aspirations. To prevent secondary lung damage, we are protecting by securing the airways.
Yeah, so that's a keyword, like loss of protective airway reflexes usually happens when the GCS is less than 8 to 10, of course. Yes. So this is the first episode of seizure. Would you already intubator? Of course, M3, B1, E1 you said.
We have initially we have waited for is there any improvement in is our baseline mental status, but since there is no improvement, we have secured the airway and then shifted for imaging, sir.
Totally agreed. So see, she may recover if it's just a single GCS, but you don't know at this time point. Of course, if it has been a status, if it's been coming repeatedly within 5 minutes or something like that, or if there is outright airway compromise, then yes, agreed. But in this situation, you don't know if it's going to come back again. And I think in your subsequent slides, looks like there has been an airway compromise. So it is appropriate. So you would have secured airway in this patient had she come. Okay, so that is all. And you also told me one more thing. You have to go ahead with imaging and all that. A very practical point, because most of the times, most of the problems happen while imaging only. So securing airway, I don't think you need to think twice about that. Okay, unless the patient looks so comfortable, there is no problem with the aspiration risk and all that you mentioned. Maybe there it's worthwhile waiting. It's a tricky call, but you just answered it well. Yeah.
Another, if I can pitch in, Uday, another issue is, the history is very suggestive, although not a classical history. Is a young female, 41 is a young female, and she has been a known case of seizure disorder, unfortunately not on medication. So she has thrown a seizure-like activity, airway compromise, and there is no history of any trauma. So that rules out essentially trauma-related issues. Now, from this slide, it is not very clear whether it is a seizure episode, breakthrough seizure that has occurred, or is it really pointing out to subarachnoid hemorrhage. So can we move to the next slide?
No, so I mean, if I can just halt there.
Yeah, sure.
I thought we'll just finish the different lines that he has mentioned about. So the second one is about phenytoin and diazepam. Would you have done the same thing?
No, sir. Initially, I'll go with lorazepam, sir. Lorazepam with 0.1 mg per kg. Then, if it is not responding with the initial benzodiazepine therapy, I will go for second-line agents such as phenytoin, lacosamide, and levetiracetam. And even with this treatment, also, if it is not improving, I will go with infusion therapy, sir. Initial bolus followed by infusion therapy of midazolam. Yes, sir.
So this also highlights another important point that, stabilization of patient should take priority over making a diagnosis. So like you said that you have intubated the patient because that was a priority, and, similarly, if there is an active seizure, it has to be treated like you suggested. So the students have to keep in mind that resuscitation, the basic life-saving measures, they take priority, and then only you will take her for a CT. If you take a patient with a low GCS who collapses because your patient was hypertensive also, and she has a mishap during CT scan, then you have it. So the message is very clear: stabilize your patient first. There is an urgency for doing a CT scan also, but you will take a stabilized patient when you have things under control. Okay. Yeah. Move on.
Yeah. Like Dr. Rajesh just mentioned, it's always you start any of these acute case presentations with the ABC. You start talking about ABC. That also gives you a little bit of warming up time to be ready. See, ABC is sort of universal and common for everything. During that time, you just categorize the rest of the answers. That's one trick I always use, at least when I used to answer. It's ABC. And by the time you finish talking about this, you should be ready with the real answer. And like Uday rightly pointed out, no, the step 1, step 2, step 3 of the initial seizure control starts with one of these agents, lorazepam, midazolam, the benzodiazepines, followed by the anti-epileptic. So you never start saying phenytoin load or levetiracetam load. And at this time point, because we are going to be talking more about subarachnoid hemorrhage, I assume in the subsequent slides, and we may or may not come back to this point. So it may be worthwhile you knowing the level of evidence behind the use of levetiracetam, and now there is this breviracetam, which are all basically extrapolated therapies. There are trials. It will be, I think it will be beyond the scope of today's discussion, but you need to know some of the Levira and the landmark trials. Okay. So what exactly is the loading dose of levetiracetam? Because I'm sure most of us, you have switched over to levetiracetam or breviracetam, these days. So you need to know where the evidence generates from, what is the actual loading dose. It's not the 500 BD that we, quite often is done in many places. It's not like that. You give a loading for even that. Okay. You need to be aware of that. And he clearly said, first, lorazepam versus midazolam, second, one of these anti-epileptic drugs, and third, he will consider anesthetic infusion. You need to be clearly aware of the concepts of what is status, what is refractory, what is super refractory, when you will switch over to other modes of therapy like benzodiazepine versus the ketamine agents, so all those things. Yeah. Sorry
what Dr. Raymond is suggesting is, the case may look simple. It is, targeting the SAH, but you need to know a lot about seizure. It can take any shape. So you need to know about the basic treatment. What will you do when an active seizure is happening? How will you manage a refractory seizure and super refractory seizure? So that all you need as a background information, background knowledge. Yeah.
But even before we move on to seizure, typically in exam, what happens is, at least in DNB exam, now it's very difficult to manipulate the IDCCM questioning pattern. You might just stop with the airway itself. In fact, I can just ask Uday, see, this is again because Sashidhar told me there is no time limit. Okay, Dr. Rajesh, I hope you're okay with that.
Yeah.
So do you want to classify or nicely define your intubation, Uday? What word would you use? Uday, are you there?
Well, yes, sir. Yes.
Yeah.
And,
See, you said I want to intubate the patient. Okay. If you want to be the topper, I would expect to hear something from you. So the first opening, present or the opening word, you hit it nice. It goes on that way.
the primary aim of the emergency intubation is to prevent aspiration, sir.
No. All that we discussed. How will you intubate this patient?
No, in neurological patients, is it only aspiration or something more?
And we have to prevent the sympathetic response.
Absolutely. You have to prevent any rise in intracranial pressure, because that may cause a rupture if the aneurysm is there and it has not ruptured. So that needs to be kept in mind. Okay, please go on.
Maybe rapid sequence intubation, that is very important. Yeah. So we would like to hear the term rapid sequence intubation. We would like to know that you will take precautions to prevent a rise in ICP. Your discussion might just stop here itself and not move further if you're not in a position to classify and describe rapid sequence intubation. Okay. Yeah. So we'll move on to the next.
Yeah, we'll move on.
Yes. And initial vital data, as I already told, BP of 170 and heart rate of 120.
No,
and
can we go to the previous slide?
Yes, sir.
Yeah.
Yes.
So here, basically you are talking about CNS. Okay, fine. And you have intubated. Fine. Let's move on. There is right-sided weakness also noticed. Okay, move on. Yeah, next slide. Yeah. And here you see your patient is borderline, has a borderline BP, he's tachycardic, and he is on high oxygen before you intervened. And again, ABG, there is, it's borderline, lower limit of the normal pH, and your PCO2 is okay, but your oxygen pressure is with 8 liter, it is 88. Lactates could be, like you said, could be high because of seizure activities. Lactates will rise because of a lot of reasons. Could be because of seizure activity, could be because of bleed, could be because of ischemia, could be because of hypotension, and then patient has a high blood sugar also. He is not a diabetic. Is she a diabetic patient?
No, sir. No, sir. No.
She's not. So the sugar is possibly, this is also undiagnosed. Sugar is also high. So my suggestion to the students is that, they should follow the way they manage these cases in the ER. Dr. Raymond very clearly said that you have to manage the patient first if you start talking about the diagnosis and the subsequent workup. So you need to interpret this data, and you would need to identify what is the severity of illness, what are the serious issues. So maybe you would like to bring up the blood pressure. So are you happy with this blood pressure?
No, sir. We have given initial bolus of fluids and continued.
So, Uday, why are you not happy with this blood pressure?
Yes, sir.
We cannot comment, sir. It could be normal to her because she has not given any history of hypertension.
Yes.
So
and what are you more concerned about? You are concerned about systolic blood pressure, diastolic blood pressure?
Diastolic blood pressures.
Why?
Because that determines the coronary perfusion. So
no, right now we are not. At least that is one organ that I decided not to talk about today. Okay. No. What are you more worried about right now?
The systemic perfusion is important.
Perfusion. So what pressure do you want?
We
are more worried about the mean arterial pressure, isn't it?
Yes.
Mean arterial pressure is always the one that governs organ perfusion. I agree. Diastolic pressure is more when you're talking about coronary perfusion. Likewise, systolic pressures become targets when you are talking about somebody who's exsanguinating. Of course, in this case, aneurysmal ruptured bleed also, especially post-clipping, pre-clipping, in the risk of re-rupture, all those. Systolic pressure is important in that context. Okay, so a given 160 may or may not be important. If this is somebody who has been hypertensive, okay, there again, because SAH is all about altered cerebral autoregulation. So if this has been a person who has been long-standing hypertension, and here you have 170, maybe you need to be worried about. Okay, but the absolute map, I would assume, for this 170 is okay. All right. But yes, again, you are going to think about, maintaining perfusion, the risk of delayed cerebral ischemia setting in and all that. So we'll come to the systolic pressure targets and all that. But I think at this time point, 170, let's say if the map is 75, I may be okay. Okay. All right. Okay. So somebody else can tell me now. ABG shows hypoxia, isn't it?
Yes.
Yeah. Now, why do you think this hypoxia? Is it that the patient is not breathing enough, or is it because the patient has aspirated or atelectasis?
We think more in terms of aspiration and atelectasis, sir.
How will you show me objectively?
Objectively, he has poor GCS, sir.
No, you, of course, clinical correlation, definitely. But in poor GCS, they may be hypoventilating also, isn't it?
Sir, but PCO2 rise is not much. It's still maintaining
Agreed.
Below 40.
Agreed.
And,
what else, when we talk about approach to hypoxia using ABG, how will you say if it is a hypoventilation or a VQ mismatch? See, atelectasis or aspiration, all that is VQ mismatch. Don't worry, we'll quickly jump over. The next slide is already MRI. So after that, I don't think we can come back to these things.
We have to
is also-
alveolar
We talk about,
gradients.
exactly, yeah, okay.
Ka gradient we have to see.
Yes. So when you talk about vitals, make it a habit to dissect each one. Why is the blood pressure like this? Is it appropriate? Am I worried about systolic, diastolic, MAP? Are each of the individual targets good? Why is there a tachycardia? Is it that a seizure related autonomic tachycardia, or is there a hypovolemia? Is there anxiety? Is there pain? Don't settle with a number, or that can be arrhythmia also. It can be an atrial fibrillation. Of course, variable heart rate. Atrial fibrillation is not unknown with subarachnoid hemorrhages, or is there a myocardial dysfunction setting in? So for every single number in the ICU, you should have 4 to 5 justifications, and you should finally arrive at one of them. Why is the oxygenation low? What is my AO2 gradient like, or what is my A by AO2 looking like? Okay. Respiratory rate. Why do you think the patient is slightly tachypneic? Isn't it? 20 is not maybe normal, maybe slightly tachypneic. Why do you think patient is breathing at 20?
Have
Due to
to
hypoxia.
because of poor GCS, maybe upper airway obstruction also we should think.
Okay, so upper airway obstruction with distress making the patient tachypneic, or like you said, atelectasis and aspiration reduction in lung volume, so the patient is trying to make it up, or maybe there is a metabolic acidosis and patient is beginning to try to compensate. Okay, or again the anxiety, pain. So it should just roll. Okay, this is typically how you will be questioned in a DM or DNB. Okay,
But
you need
again,
to.
if you look at the numbers, I would be concerned because blood pressure 100/70, patient has a heart rate of 120, so I'm concerned whether
Yes.
he's trying to compensate, she's trying to compensate, and that is how the BP is maintained, because the saturation is also low, the pH is borderline, and she's requiring high oxygen, the GCS is low, the lactates are high, the sugars are high. I would consider this a critical patient. I would rather react to this blood pressure. I would like to settle down the heart rate. And so this would be a cause of concern. Any other patient where other things are not there, the heart rate is settled, maybe I will accept 100/70, but not in this situation. That is my take.
Agreed. Yeah.
Okay,
let's move on.
shall we move on? Yeah.
And after securing airway, patient shifted for MRI brain, sir. Initial MRI brain is showing a subarachnoid hemorrhage.
Now, if I can stop you here, what should be the primary imaging modality here?
Non-contrast CT, sir.
Non-contrast CT.
Non-contrast.
So do you think a non-contrast CT would have been better? If yes, then why?
In initial settings, a non-contrast CT is beneficial because if it is less than 6 hours, there is a possibility of picking up the hemorrhages, especially subarachnoid hemorrhages, will be ideal for going with non-contrast CT, sir. If patient comes within 6 hours.
Yeah, the
yes.
sensitivity in initial 3 hours is 100% for an NCCT to pick up the subarachnoid hemorrhage. The sensitivity is reduced, say after 5-6 hours to 50%. So initial investigation, and it will reveal you other intracerebral bleed, many other things also, isn't it?
Yes, sir.
So I think the investigation of choice, it should be very, very clear. You should speak in the exam what you actually do in your setup. So the standard mode of investigation that you do quickly is an NCCT brain, which is very useful, which is recommended also here in these kind of patients, because you would like to rule out the, suppose, what could it be? It could simply be, an excess, a breakthrough seizure because she missed her medication or she was not taking her medication. It could be an ischemic episode. It could be a hemorrhagic episode. So even if you consider that there is a remote possibility that this might be an ischemic attack, because history and clinical symptoms normally are not very, very suggestive, because the classical brain bleed where you have vomiting, nausea, intractable pain, those classical features are not there. So the telltale signs that you can pinpoint that this is subarachnoid hemorrhages are they're not there. So you would like to, if you have to rule out any bleed, so that if it is ischemic, you can start your anti-ischemic therapy. Plus, if there is a bleed, then you know what you need to do, whether it is subarachnoid bleed or it is something else. It is an plain simple intracerebral bleed. So that is very, very important. Then you move on to other investigations. As such,
Also-
yeah, please, Raymond.
No, you complete.
So now coming back to MRI, where is MRI useful? Since MRI was done,
Yes.
no, in the setting where like MR is showing subarachnoid hemorrhage. So subarachnoid hemorrhage would have been visible in a CT scan also. So what more information do you get from MRI brain?
After the as a sensitivity is usually when compared with CT scan sensitivity is decreases as duration increases, and in MRI in MRI there is increase in the sensitivity and specificity as the duration increases, sir, because of hemosiderin deposition makes it easy to pick up the subarachnoid hemorrhage in later stages.
Absolutely. So in FLAIR images, it has a high sensitivity for heme. So these days, classical in our days, if there is confusion, we are not sure, then we would be doing a lumbar puncture. And these days we don't do a lumbar puncture because, the bleeding could be because of a traumatic puncture. So the best way is MR there. It will rule out whether it is, or rule in whether it is subarachnoid hemorrhage or it is not subarachnoid hemorrhage. So that is a good point. Yeah, Raymond, you wanted to add something?
Nothing much. Again, the points between CT and MRI. One more thing is, of course, the ease of doing a CT. This is
Absolutely.
potentially a person who's going to get unstable any moment, and we are talking about hemodynamics. So I would rather not take her up for the MRI. Practically, so many things are so difficult, monitoring, equipment, and all that. It's doable, but just the ease of stuff. And MRI is also something that underplays hydrocephalus. Not that it already happens in an acute setting, but MRI picks up hydrocephalus a lot less apparently than a CT scan. Yeah, go ahead. Fine. So let's say, because you've mentioned this line, subarachnoid hemorrhage in bilateral cerebral sulci, sylvian fissure, basal cistern. Before even the radiologist tells you, of course, we need a little help from the radiologist to tell us about where exactly the aneurysm. Sometimes certain things will be obviously, visible, but otherwise we need some help. Based on the pattern of the blood, can you say if it is, because again, the history is not very typical, like Dr. Rajesh mentioned. Looking at the pattern of the distribution of blood, can you say if it is traumatic, non-traumatic?
Usually in traumatic subarachnoid hemorrhages usually involves the convexities, that is peripheral lesions. In aneurysmal bleeds, aneurysmal subarachnoid bleeds usually involves the basal region, that too in the involving the basal cerebral sulci and sylvian fissures and interhemispherical fissures. These fissures are usually involved in the aneurysmal bleeds.
Exactly. So commonly it's a cerebral sulci which get involved. I mean, not that it will not flow into or extend into other areas, but quite common. Traumatic, we tend to see the sulci getting filled up. And again, in only extremes of aneurysm ruptures, first it fills up the basal cisterns, all the subarachnoid spaces, and then it goes up to the cerebral sulci area. Yeah. So this is already a high grade, like you mentioned. Can you just, for the benefit of people who are listening, can you tell why you're calling it grade 4 and how you will do a CT grading?
If it is involving more than one fissures as in the sulci, it is considered as thick SAH, and grading depending upon the modified fissure grades, it is classified as a grade 1 to 4. And in grade 1, there is thin SAH, that is only one fissure or sulci involved, and without any intraventricular bleed. And coming to grade 2, that is thin SAH with intraventricular hemorrhage. And grade 3 is thick SAH without IV intraventricular hemorrhage. And grade 4 is thick SAH and with intraventricular hemorrhage.
Yes.
So can you also tell what is the difference between a plain fissure grade and modified fissure grade?
And
fissure, the plain fissure grade would also look at the neurological presentation. So here it is only looking at the bleeding pattern. So that was the classical thing. Whether it detects a blood, again, most of the things are same. Sorry, that is Hunt and Hess. I confused with Hunt and Hess. Hunt and Hess is no longer used. So Hunt and Hess will look at the neurological impairment also. Whereas Fisher looks at the basically the CT presentation of bleeding pattern. So more or less, if you look at the Fisher and modified Fisher, the difference is marginal. It is more refined. For example, it talks about thin and thick, whereas the old one just mentioned about clots. Grade 3 was clots, or grade 4 was ICH or intraventricular clots. So here it is clearly defining that there is bilateral IVH or there is a thick SAH. So that is the only difference. Otherwise, it focuses on your bleeding pattern only. But this Fisher grade 4 would be the highest grade, isn't it?
Yes.
So that means the risk of high mortality and high morbidity is very high.
Yes. And vasospasm risk also.
Vasospasm also would be high. Any idea about the mortality based on what you have presented so far?
It is more than 70%. Yes.
Okay. Yeah, please move on.
Yes.
Are you aware about?
Everyone needs to be aware of all the scores and the classification. The World Federation, of course, Hunt and Hess isn't used too often. It's more of a theoretical discussion, but then you all need to know all these, especially with a prognostication or a outcome modeling sort of an outlook.
Yeah, you need to know the World Federation score. So that is very important. Can you tell us about that a little bit?
Yes. World Federation score is basically depend upon the baseline GCS, and it is graded from 1 to 5, and here grade is 5, and
baseline GCS and motor deficit. These are the two things it looks at.
Yes. In grade 1, the initial GCS was 15, and in grade 2, GCS was 13 to 14 without deficit, and grade 3 is the initial GCS of 13 to 14 with deficit, and grade 4 is 7 to 12, and grade 5 is less than 6 or less than 6, and that's 3 to 6.
Absolutely,
Yes.
Great answer.
Yeah, and
any other score that you are aware of, just for curiosity's sake and just so that people will know?
Hunt and Hess,
Hunt and Hess is fine. That is based on the symptomatology, the neurological impairment. Have you heard of PASH scale? PAASH? That is another one. It's basically totally based on GCS. It's a prognostic scale. So again, the grading would be similar, like 15, 12 to 14, 8 to 10, 4 to 7, and GCS of 3. So it's, but the most widely used is World Federation and your modified Fisher. So these two, the students are expected to know. This will be definitely asked in the exam if you have a similar case. Yeah, please move on.
Hunt and Hess grade is 4, sir, and the next GCS is E1 VTM3 after post intubation. We have started on a nimodipine infusion and also anti-epileptics levetiracetam and lacosamide was started, sir. And initially she is required to maintain maintain of systolic blood pressure of more than 140 and required low dose noradrenaline support, and interventional radiology team is involved for 4-vessel angiography, sir.
Again, can I just ask why lacosamide was added on? Did she have repeated seizures or something?
Because of repeated seizure, no patient is a known seizure disorder, and she is requiring 2 drugs to control the in outside hospital. She is requiring 2 drugs. Then initially we started.
She was loaded phenytoin and given diazepam and shifted to you.
Yes, sir. And initially we started levetiracetam, and upon neurologist consultation they are escalated to.
But generally, what is the recommendation for seizure prophylaxis in SAH?
In SAH, usually seizure prophylaxis is used up till aneurysm is secured, sir. And after securing aneurysm, there is no need for continuing seizure and anti-epileptic drugs. In case patient starts with seizure activity, we have to continue this anti-epileptic drugs, sir.
Agreed. Yeah.
And would you give prophylactic anti-seizures? Patient has not bled, but he has been diagnosed to have an aneurysm, say ACOM aneurysm?
Yes, sir. Till till the time we are securing the by coiling a clipping.
No,
aneurysm,
patient has not bled.
No.
There's no subarachnoid
Not
hemorrhage. It's a
required.
chance.
Not
It is
required.
not required.
not required.
So no recommendation for prophylaxis. In fact, the use of your patient has a background of seizure disorder. Otherwise, in this subarachnoid hemorrhage, there is no clear-cut recommendation for anti-seizure prophylaxis. The literature is divided. 20% of the patients will have a seizure. The problem with seizure is the surgeon will give to all, because the chances of, if God forbid, if patient has a seizure, then the chances of rupture of the aneurysm are very high if it has not already ruptured. So the seizure prophylaxis is given after bleed to all the patients until, like he said, that we have secured, if it's an aneurysmal bleed, until we have secured. Yeah,
but
please.
in practice, it seems like
Absolutely,
difficult to stop it.
Absolutely.
Because I mean, looks like, of course, we don't have class 1 evidence, but then maybe their fears are also genuine. When you increase the cerebral metabolism, you'll end up with a delayed cerebral ischemia.
Absolutely.
But we don't know. No one knows what's the truth. Okay.
See, this is a surgical subject. Has been a domain of the surgeons. That's why very little is known. If you compare with acute ischemic stroke, you have numbers, guidelines, everything
True.
very well defined. Here, you are not sure about anything. Even blood pressure, what Dr. Raymond was talking about, we are not sure. There are no clear-cut recommendations or numbers here. Anyway, we'll talk about that. Yeah, please continue.
Yes. Endovascular, after consulting with IR team, patient shifted to cath lab, and endovascular coiling of anterior communicating artery aneurysm is done, and anti-edema measures for Mannitol IV started.
So how early should an intervention be done?
As soon as
Is
possible.
it mandatory to take up the patient immediately, or you can stabilize and take after some time?
Up to 3 days we can take, sir.
Sorry?
Up to 3 days, sir. Up to 3 days.
Yeah. So again, there's a lot of debate whether you need to do within 24 hours or within up to 72 hours is okay. But of course, available evidence says that there is no major difference, or no major difference whether you do it within 24 hours or within 72 hours. But typically, coiling can be attempted within 24 hours. It doesn't require major stabilization. But if it's a clipping, or for some reason we decide on surgical, then priority comes for pre-surgical stabilization, which means that if it's going to take a little more than 24 hours, it's okay. But your answer in an exam will be early, between 24 to 72 hours. I think it's a best clinical judgment on the bedside. Okay, Mannitol. Why was Mannitol given here?
Initially, patient presented with seizure activities. We suspected raised ICP. So we started a Mannitol.
But the MRI didn't show any edema, isn't it?
No, sir.
So how do you, how does Mannitol really help? How did you give, can you just nicely elaborate on this? Because this is always one hot topic, Mannitol and 3% saline.
Mannitol is osmotic diuretic, which increases the serum osmolarity, which draws the blood from the extracellular. Cell shrinkage can be done, and from shifting of fluid from intracellular compartment to extracellular compartment, which draws the by osmotic power, and reduces the cerebral volume. By reducing the cerebral volume, it improves the ICPs.
It reduces the viscosity, sir.
Yeah. So there are, in fact, many mechanisms that some 4 or 5 mechanisms they talk about. One is, of course, viscosity, and then improving rheology, the way the microcirculation functions, and then, of course, the osmotic effect, drawing in water from the cells into the intravascular compartment and all of those. But all that will happen only. See, there is a common mistake that is still often done in many hospitals. That is, mannitol will go over 30 minutes, 40 minutes, 1 hour. Mannitol will exert its effect only when given as a very rapid bolus. And again, you need to be giving something like 1 gram per kg per dose, which may be like 60 grams, which is not just 100 or 150 ml. If we are using conventionally in India, we use a 20% mannitol. Okay, so that means you need to give like 2 bottles or even 2.5 bottles for a 50 grams. Okay. So how often do we really do that? And typically, again, at least an exam answer is that you will use mannitol 20%, 1 gram per kg per dose, as frequent as, of course, here you've just given a stat, agreed. But if you're using that for an osmotherapy, you need to be using it every 4 to 6 hours with monitoring of osmolality. You need to be able to achieve a serum osmolality of 320 milliosmoles per liter. Okay. So unless we do all that, the practice, if you're giving 100 ml every 8 hourly, that also, if it gets delivered over 1 hour, half an hour, and all that, it may or may not really, it may land up doing harm because of what we call as the rebound phenomenon. Okay, rebound increase in ICP, which is known to happen with mannitol. So I'm not again favoring mannitol or favoring 3% saline. There's always this debate going on. So you should know the pros and cons for each one. We've still not been able to prove or disprove which is superior, which is better. But for various reasons, what will be your choice, Uday and Shilpa? Mannitol or 3% saline? See, both can be correct answers depending on how you do. It's all the institutional preference and your ease of practice and all that. What would you personally prefer?
If we take this scenario like subarachnoid hemorrhage, where we are worried about maintaining the euvolemia, I would like to prefer 3% NaCl over mannitol because of the intravascular volume contraction.
Yeah, isn't it? So that's a very important point you made, euvolemia, because we start with a BP 160, you're using noradrenaline already. There is a high grade SAH, which means there is a high risk of ensuing vasospasm and DCI. So mannitol, you really need to be careful. And again, 3% saline seems to be something that you can titrate. Of course, the first dose again has to be a bolus. That is something you can titrate. We nicely take the serum sodium up to 150, 150 to 152. You know, you can maintain the osmolality nicely. So my personal preference is always hypertonic saline. But in this situation, I think you've clearly said they want to take for an endovascular intervention. So immediately before that, they want to sort of dehydrate the brain or something. So it has been done. So this is again a common practice, not to discredit. It's a very common practice for fear of cerebral edema, and you know, intervention also gets difficult. And during intervention, there are so many things that happen which increase the incidence of brain edema and all that. Yeah. Okay. So everyone needs to, before exams, at least if it is something to do with neurology, definitely there's going to be question on osmotic therapy. You need to have clear ideas, clear pros and cons for each one of them.
See, again, in the setting of subarachnoid hemorrhage, when the ICP is not raised, this would be counterproductive, this osmotic therapy, so osmotic diuretic therapy. So that you should know very, very clearly. So if there is clear evidence of intracranial rise in intracranial pressure, significantly increased, then you will talk about hypotonic saline. Otherwise, you see what happens there, the tamponade effect is gone. Once you shrink the brain, the chances of bleeding or opening of those vessels will be there. So and plus you are causing, by mannitol obviously would be a wrong choice, because you would be causing dehydration, which is clearly against the standard recommendation. From triple H, we have moved to 2H, double H. But essentially, we are not dehydrating the patient. So that you must keep in mind.
Yes.
Yeah, more.
And we continued hydration with 100 ml per hour saline. And we continued.
So these two, if you give this as an explanation in the exam, on one hand you are dehydrating, on the other hand you are pumping in saline. So this should not be done. Okay. Yeah.
And for pain control, we have started a fentanyl infusion and intermittent PCM 1 gram every 6 hourly we have given, sir. And the pneumatic compression devices were placed.
So can I ask Uday you a question to both
Yes.
of you? Why coiling was done? Why open surgical clipping was not done? Can you explain?
And
It is a ECOM aneurysm, sir. The patient has like we can go for both endovascular clipping or endovascular surgical clipping or endovascular coiling. But if that is the scenario, the literature says it is always preferable to go for endovascular coiling than the clipping.
Why?
Because of the ISAT study where it has shown the chances of rebleed within the 1 year, the chances of recurrence of the subarachnoid hemorrhage.
Dependency or death? The chances of dependency or death,
Yes,
they are much higher with
Dependency.
open surgery as compared to clipping, isn't it? The ISAT trial. And then there was one more trial. Have you heard of the BRAT trial, BRAT?
Yes.
This was a single center study which showed a similar kind of results, but then they said that after 3 hours and at 6 hours, there was, no impact. But then there were a lot of crossovers in their study from one arm to the other, and it was a single center study. So by and large, if you have the facility, endovascular treatment is the treatment of choice, isn't it? So now that leaves our surgical colleagues very unhappy if we give that blanket statement. So what are the situations where you would go for surgical clipping, open surgical clipping?
with aneurysmal bleed with large hematoma that needs evacuation, and the aneurysm base is very wide. The chance of failure of coiling is more with broad-based aneurysms. In these cases, I tend to go for clippings rather than coiling.
Mm-hmm. But this will also depend on the endovascular expertise also. In this BRAT trial that I spoke to you about, they were randomized to either go for open surgery or to go for endovascular coiling, but almost 25, 30%, 33% were sent back for surgery because they found the area was not accessible. They were not confident about handling that endovascular way. So generally, you will select the younger patients. So that is, open surgical treatment, basically morphological characteristics, associated large hematoma, like you said, and patient should be young because there is no scar, the morbidity is much less. So that is important. The duration taken is also, surgeon can quickly do it. The risks are less. So those are some of and plus it should be in the anterior circulation. Then only you will address it. As you would know that most common aneurysms are in the anterior circulation, then middle cerebral artery, anterior ACOM, and then the middle cerebral artery, and lastly the posterior circulation, isn't it? So this should be the ACOM type. So again, this would depend on center to center. There is no hard and fast, debate on this. This would depend on the if you have an excellent interventionist, possibly the treatment of choice would be endovascular coiling. Yeah, please go on.
What is a major problem with surgery? Shilpa and Uday?
Yes.
Retraction injuries, okay, delayed, we talk about cranial nerve palsies or delay in recovery. No, it commonly happens because of retractions that are used while trying to access. That's one of the major reasons. Well, like that, what is the big, most feared complication of coiling?
Coiling, if it is while doing the coiling, if the patient has rebled, then the mortality goes doubles. If it is during the clipping, if there is a rebleed, then the chance of mortality is half of that.
Yes, and I mean technical aspect, coil migration, that is something which is dreaded.
See, again, if you look at the techniques also, when they do an open surgical clipping, they will be putting temporary clips on all the adjoining vessels, and they will see, then they will put the main clip on the aneurysmal neck, and they will see whether there is any bleed, and then they will open. So whereas when you are doing endovascular coiling, you are trying to enter into the aneurysm, and you are trying to put coil there and obliterating it, facilitating thrombus formation. So possibly surgically, if it is accessible, you have better control. Again, debatable. So we are not surgeons, so or endovascular neurologists, so we will not comment on that. But these are the two aspects.
And multiple aneurysms at a time, we can even secure.
Yeah.
Yes, yes.
At this stage, I mean, of course, before we move to day 2, is there a role for tranexamic acid, antifibrinolytics?
No,
Ultra short therapy, sir. Prior to securing aneurysm, we can try, sir, because it has shown a good functional outcome. But post coiling, post securing the aneurysm, there is no role, sir. But again, some of the studies have shown that there is increased systemic and local thrombosis. So currently, we don't practice.
Yeah, in fact, I think it shows no difference whether used or not. It actually shows no difference. Immediate rebleed, pre-aneurysm, I mean, pre-procedure, pre-intervention rebleed, or 6 months, there is no difference. So because we were talking about trials, I remembered this one. Ultra trial is something that you may want to just read up. It's a large-scale trial, so you may, exam goers will read that up. Please move on.
Again, for antifibrinolytic, one of the suggestions is that if you are not a center that does either the aneurysmal surgery or does endovascular coiling, and you have to send him to a referral center, then, and it will take a while, then you can give antifibrinolytic. Otherwise, I think in general course, there is no indication now, no recommendation.
Please move on. Day 2.
yes, sir.
OC.
And initial investigations for ECG was normal, no STT changes, and chest X-ray was normal, and echo there is no Takotsubo lesions, and hemoglobin of 13 grams, and total leukocyte count is 12,000, platelet count of 2.64 lakhs, and initial sodium of 136, and serum creatinine 1.2 milligram, and blood sugars lab values of 112. Yes, sir.
In echo, you said something. What was that?
In case of subarachnoid hemorrhages, because of activation of sudden surge of sympathetic activity, raise in catecholamine levels, which causes apical ballooning of heart. When we see in the apical
So I understand that. My suggestion is, if it is a normal study, just mention normal study. Okay. When it is a normal study and you are trying to tell that, you know, Takotsubo is excluded, then you are inviting a fresh set of questions, because you are now throwing the weight of your knowledge that I know that, you know, he can also have Takotsubo. So limit your answer, leave something for the examiner also. So exam strategy, eco normal, fine, move on.
You said Takotsubo. I'll ask you, what is the role of dapagliflozin in management of Takotsubo? What is the recent evidence? Okay, move on. That's on the lighter side. Yeah.
And day 2, patient is on ventilator.
So that sodium, definitely we would not allow that sodium, isn't it? 136. It seems to be on the lower limit of normal, but we prefer to have it at least above 140. Creat is 1.2. Okay, I'm concerned. Yeah, move on.
Yes. And in day 2, patient is on mechanical ventilator support, and GCS was improved from E3 M5, and patient is not following commands, and pupils were equal and reacting to light, and she is requiring low dose noradrenaline support to maintain BP, and after placing ribostop, tablet nimodipine 60 mg 4th hourly started.
So we haven't spoken about nimodipine. Why is nimodipine used in almost all cases of subarachnoid hemorrhage?
To prevent vasospasm, calcium channel blockers, non-dihydropyridine calcium channel blockers like nimodipine is used, sir. And in subarachnoid hemorrhages, there is a possibility of secondary neuronal injury, secondary to vasospasm and rebleeding will be seen. And to prevent vasospastic secondary injury secondary to injury vasospasms, nimodipine is used, sir.
To reduce the delayed cerebral ischemia, sir, mainly, it has like not for the, rather than a vasospasm, for a good functional outcome and for a delayed cerebral ischemia events to reduce.
Absolutely, because they find there are factors, other factors also, which are responsible for vasospasm, which are unknown to us. So it improves the functional outcome and it improves the overall outcome also, like the delayed neurological recovery. So that is why we use it. How does it work? Nimodipine?
Nimodipine.
By raising the cyclic AMP levels intracellularly, it causes vasodilatation, sir.
Yeah, it basically relaxes the vascular smooth muscle by acting on the calcium channels, correct?
Yes.
Okay.
And it may be worthwhile you people just being aware of the 2007 Cochrane database, which is the one that we refer to when talking about nimodipine role in SAH. Okay. You'll want to go and read up about that. Okay.
Yes.
And theoretically, you know, there is, if it is an exam, we tend to ask you the mechanisms why there is vasospasm. Again, more of a theoretical answer. Please move on.
Yes, sir. On day 3, patient is continued on ventilator support, and GCS was E3, M5, and V3, and patient is not following commands, and pupils were equal, and there is no improvement in GCS. We have done a transcranial Doppler. It is showing maximal flow velocity in left ACS, anterior communicating artery, and started on 3% NS, and nimodipine was continued, and then imaging was done, sir, to rule out any vasospastic.
So any comment about the utility of TCD or the recommendations about TCD?
Transcranial Doppler usually picks up vasospastic secondary injuries in nearly 70% of cases, sir.
Yeah.
Because of this advantage, we tend to use a transcranial Doppler on every alternate day, because vasospasm incidence comes from the 3rd day to 14th day, peaks around 4 to 7 days, sir.
Absolutely. So although it doesn't pick up all cases of vasospasm, there is inter-individual variability also. There are no standard recommendation, must-use recommendation, but it is a very good bedside tool. So in clinical practice, you can know about the vasospasm without shifting the patient anywhere. So this is something that we need to do in these patients in the post, corrective measures time. I mean, post coiling or post surgery, we must do. Okay.
Yes. And repeat imaging done, sir. Repeat imaging MRI brain was done on day 4, and showing acute infarct corresponding to anterior circulation. This is MRI showing anterior circulation infarct. This is the ADC image, sir. Hypointensity seen in the anterior circulation, and then interventional radiology team is involved. 4-vessel angiography is repeated, and intraarterial injections in intraarterial vasodilators, nimodipine and milrinol was instead, and then patient shifted back to the ICU, sir. Yes, sir.
Any idea how much dose of milrinone was used? Of course, we use intraarterial nimodipine. I know that milrinone is done. How much was used? Any idea?
No, sir.
That's okay. That's okay. That's okay.
How does milrinone work, and where it has classical indication, the maximum use outside, I'm in this domain?
Usually, in case of severe cleavage, inodilator activity.
Yeah, you were saying something?
In case of raised pulmonary vascular resistance, sir.
Absolutely. Right heart failure due to raised pulmonary resistance. It's a very good pulmonary vasodilator. So those are for right heart failure. This can be used. The surgeons use it regularly post-surgery. So this is the preferred dilator as compared to dobutamine by most surgeons. So use largely is confined to the CTVS ICUs, and once in a while in medical and the cardiology ICUs. Okay.
Yes, sir. And on day,
Yeah, this you showed.
yes, on day 5, patient GCS was E3M5. Patient underwent a tracheostomy and started weaning to pressure support mode, sir. And on day 6, patient shifted to rehab, sir. Actually, on day 5, patient underwent tracheostomy. As the patient sensorium remains to be the same.
Can you just tell why you decided on doing a tracheostomy on day 5? I mean, I would have done the same thing as well. I just want to hear it from you.
Yes, sir. Actually,
Because GCS is 8T almost, just that M6 alone.
And initial grade of SAH was
Good.
it's a poor grade, sir. And,
So there typically, yeah. So your prognostication is that they're going to need long-term airway protection. I mean, long time for recovery. Not that you can prognosticate airway requirement. Yeah.
yes, sir. And also he had a secondary neuronal injury by corresponding acute infarcts. Needs further prolonged ventilator support.
See, if you look at these patients where there is a aneurysmal bleed, 50% will have, even after correction of the defect, they will have neuropsychological issues and they will have decreased quality of life. So this is a devastating disease. And here your patient had the highest modified Fisher grade, isn't it?
Yes.
So that was a very high risk. Plus he had problems post coiling also. So I think, he's going to be needing a ventilator. He's going to be obtunded for a long period of time. So that is why you decided to go for an early tracheostomy. Just by the way, how do we define early and late tracheostomy now these days? And should we wait in not this particular case, otherwise in normal ICU patients? So what would be an ideal time to consider tracheostomy?
Early is up to 4 days, after 4 days, sir, and the delayed is after 7 days.
Is it so, or
You belong to the pre-2014 era.
what is the harm in doing early tracheostomy? Let me ask you that. This question is not pertaining to this case. Normal ICU patients where you know that patient needs a, if you decide on the 4th day, the fear is a lot of these patients may have been weaned without any tracheostomy. So that is why earlier we used to take that 10-day period, 1 week, 10 days. Before that, we call it early, and after 2 weeks, we call it late. But now we would tend to wait at least 10 days, 10 to 14 days before we embark upon tracheostomy. So that we know, unless, of course, neurological cases, neurosurgical cases are an exception, because we know based on the clinical, condition as well as the imaging, that this patient is there for long haul. So we need to start the long-term care measures, which of course includes tracheostomy.
So in fact, I'm surprised your neurosurgeon allowed you to already go ahead with a tracheostomy. He didn't ask you for a trial extubation because 8T, day 5, I'm really tempted. See, you can always argue this way, that way. It is quite possible this patient might have maintained airway, might have handled secretions. So many things which unless you extubate, you will never come to know. Again, that's all not for the exam-based discussion. So you didn't hear me. So there's no harm, like Dr. Rajesh said, there's no harm waiting for 7 to 10 days, but provided, your infection control measures, and because you don't want to do all this good work and then land up with a infectious ventilator associated complication. So timing of tracheostomy, again, I think is best bedside judgment. You don't want to overdo it. So you didn't try pressure support before tracheostomy. Could the patient have done pressure support on day 3? Day 3 itself, patient became 8T.
Yes, sir. Actually, On day 5, we tried, sir, actually. On initial days, patient had requiring any interventions. We continued on control mode.
Because first day itself you finished your aneurysm, the coiling,
Filing.
and then I think day 3 or something, day 4 is it the intra-arterial injection you gave? Is it?
In
But
between-
again, see, so you don't have to necessarily, unless you are at a position to tightly control PCO2. Again, what will your PCO2 targets typically be in these patients if there was a raised ICT?
32, 35. sir.
See, for by and large, eucapnia is what we
Absolutely.
expect. So, you keep it at 35, 34 to 36 or something should be okay. Definitely, we don't hyperventilate. We don't aim for anything less than 32. That is for sure. You cannot allow it to go beyond 40 also. That is clearly no. So you target eucapnia. If that is possible so there is no harm of doing a pressure support ventilation. Again, don't think that, of course, if your patient is agitated, there is ongoing seizure, or the patient is not triggering because you are using neuroprotective measures, those are situations where you would continue control ventilation, because you need to judge everything. It's not just the neuro critical care that is going on. You need to simultaneously think of the risks of ventilator-induced diaphragmatic dysfunction, because you don't want to come out. Those are the reasons why we often land up with a prolonged ICU stay, morbidity, having to cling on to post tracheostomy. Also, you land up being connected to one of these devices. So everything runs hand in hand. Okay. So pressure support, I don't think is a contraindication, at least in this given setting, where I don't see too many pointers towards raised ICT. Again, we didn't typically discuss management of raised ICT. That is one thing that will also come in the discussion. If your patient did have some sort of clues towards raised ICT, that becomes a entirely big discussion in its own respect. You have any more slides, Uday?
No, sir.
So if I may ask you a very naive question, how do you define pressure support mode? Very simple. Any mode for that matter. So likewise, how do you define, how do you identify, or how do you, in terms of initiation, limit, and cycling, how will you describe pressure support mode?
No,
Very
just
simple.
say, yeah, please.
Initially, for pressure support mode is a weaning mode, sir.
Yeah,
And weaning mode.
absolutely.
Yeah, it's weaning mode, and we usually tend to start with a peep of 5. And,
No. What I was, the corrector of the
patient
absolutely.
triggered and the flow cycles.
Patient triggered, pressure limited, and flow cycle,
Flow
isn't it? That describes the pressure support. Now, suppose, Dr. Shilpa, you have put the patient on pressure support. Put the patient on pressure support, and you find the nurses giving you frequent calls. Sometimes the tidal volumes are too low. Sometimes the tidal volume are too high. You are not keen on putting her back to any assist control or SIMV. So, is there any other mode, similar mode, where you can have a volume guarantee? You don't have to visit so often. Have you heard of volume support? Volume support.
Yes.
Can you tell me about volume support? Very basic question. Shilpa and Uday?
So Dr. Rajesh already gave you the clue. He described what he wanted or what the problem is.
Patient triggered and the volume cycle.
Sorry.
Volume limited and patient triggered and flow cycle again.
Well, I'll make it simple for you, Shilpa. It is variable pressure support. It's a dual mode. It's variable pressure support, where you have given the ventilator a target of a certain volume and given it liberty within the set upper and lower pressure support limits that it can increase or decrease to come up to that level. So it will try to, it's like PRVC. What is PRVC?
Pressure regulated volume controls.
So that is, the correct name would be variable pressure control, isn't it? You are basically, it's a pressure control mode, which is targeting the volume that you desire, because most of our therapies are volume centric. So you say, I want 400 tidal volume. So that is why PRVC is never an initiating mode, because it needs some initial data to look at the pressure volume relationship. So if you put PRVC as the initial mode, your patient will hypoventilate. So initial, after intubation, has to be pressure or volume control mode. And then after 5 minutes, you can make a switch if you are fond of PRVC mode. So that is variable pressure control. This is variable pressure support. These are dual modes. Okay.
Yeah, there have been some questions in the inbox, I think most of which has been addressed. This one is interesting. I'll just read out, Dr. Rajesh.
Yeah, sure.
So, see, can we use MRI finding to classify Fisher grading is a question. Interesting, because typically it is with a CT only, but I don't see why MRI cannot be used, but typically it is CT based scoring. And I don't know, maybe a radiologist will be able to answer better. The thickness of the so-called SAH, what we see in CT, is going to be different from what we see in MRI. So I don't know how to correlate. You have an answer to that, Dr. Rajesh?
No, but generally bleeds are better seen. The investigation of choice for bleeds is CT.
CT.
Yeah, and for ischemia and other final things, then you go for an MRI. So I don't know.
So typically we don't try to give the Fisher grading using MRI, but why are you thinking all these things? Okay. Doesn't hyperosmolar therapy increase chance of rebleed?
That we answered. That we answered.
We have answered, yeah.
Yeah,
Which one should we prefer once vasospasm sets in, coiling or clipping? Once vasospasm sets in. See, I think the preference between coiling and clipping, to my knowledge, doesn't change about vasospasm, with or without vasospasm. It's all the same points which we already discussed.
But again, to answer your question, you see, if you are allowing vasospasm to set in, that means you have delayed your definitive therapy by at least 3 days. So a lot of secondary damage because of vasospasm has already occurred. So that may not be, the neuronal injury that you have caused will have its impact. So the therapy has to be done ideally before the vasospasm sets in. So, there is no recommendation based on the vasospasm, whether this is better or that is better. That is not the criteria. So generally it is the, the long-term outcome, the disability, the dependency and death, which have been looked at in the ISAT study. And they found that it was significantly better in the endovascular coiling group. So that is why we prefer to go for endovascular coiling. From patient perspective also, this is very safe. No opening, no prolonged surgery, no brain infection because of this. So a lot of plus points are there.
Uday, do you want to take that next question? I'm sure you must have done some literature review and all that. Intra-arterial versus intravenous nimodipine. Which has more advantage? You want to tell? Or even Shilpa? Again, there is no class 1 evidence. We don't know between these two, but yeah, I don't think there is a class 1 recommendation for this between these two. Intra-arterial is not straightforward. You require the expertise. Intravenous is easier done, but of course you need to, the basic principles need to be strong as for you, maintaining euvolemia and eucapnia, euglycemia, avoidance of seizures, avoidance of anything that is going to increase your cerebral metabolism. These are all things that you need to focus. And intravenous, or for that matter, even enteral nimodipine given in the dose 60 every 4 to 6 hourly is good enough, in fact. So I don't think more than intra-arterial versus intravenous. The intravenous versus oral also, there is no class 1 superiority of one over the other. Is it prudent to give injection Lasix in neurogenic pulmonary edema? Dr. Rajesh, can you help me with that?
Well, that is completely offbeat question, not related here. Well, neurogenic pulmonary edema, of course, you will have to unload the heart. So this therapy would remain standard. Pulmonary edema of any cause, the therapy will have to be standard. Obviously, you have to look at the neurological cause also and rectify that. So that's how I would put it.
Yeah. And difference between thin and thick SH. No, in grading, no, we use that. Uday also mentioned thin SAH without intraventricular extension with intraventricular extension. And then you have a thicker one. I think 3 millimeters or something is what is defined. So that's what I...
Uday, can you
Yes.
clarify thin is less than 1 mm?
1 or 3 mm?
Uday?
No, sir. Actually, involvement of fissures, number of fissures.
No, if you look at the old classification, then it was 1 millimeter, which was the differentiating feature, if I remember correctly. So more than 1 is thick. Again, I'm not sure. So you guys have read the subject, so you can tell better.
Yeah.
In literature, they said more than 1 fissure involvement labeled as a thick.
Okay, more than 1. Yeah. So 1 is the discrimination. Less than 1 is thin. More than 1 is thick. Okay. Any more questions?
So whenever you get something like this, okay, SAH, I mean, I'm sure you get a little time to think about it before you actually meet the examiner. So these cases are practically standard. Okay, you need to categorize, classify your pattern of thinking and how you're going to project the answers. Always, like I told you, ABC is the warming up period for you. You assess the examiner, you set your priorities of management, and then once ABC is done, the basics of care. This applies for anything. In our case, SAH. So you need to be aware of what are the priorities, the metabolic priorities, hemodynamic priorities, oxygenation priorities, ventilation priorities, nutrition, the usual ICU care processes, and what are the complications that you always think about. So standard for SAH, the first one becomes rebleed, second one early brain. So this is something we didn't talk about, early brain injury, which is a term that is these days being referred to. The global cerebral edema, there are so many hypotheses why it happens and how you can probably mitigate. So rebleed, early brain injury, and then we have these problems with delayed cerebral ischemia, hydrocephalus, SIADH. Okay, so be ready for all these standard questionings. And again, you can land up anywhere. Like, we started talking about pressure support like that. We can also move into fluid, which will be your preferred fluid in these patients. Okay, and then osmotherapy is something you definitely need to be clear about your concepts, how it acts. See, we may not really be in practice be monitoring serum osmolality every 6 hourly like it is described, but you should at least know what you are doing. If most of the times it's like a placebo effect, the mannitol, especially when it's used.
See,
So you need to...
One more thing you may be asked is, non-aneurysmal causes of subarachnoid bleed.
Oh,
so
yes.
Whenever you talk about the differential, so Uday and Shilpa, if you can tell us.
Should think of AV malformations
Okay.
and also mycotic aneurysms due to any infection. And
Trauma.
trauma.
First thing is trauma, yes.
Any tumors of brain and spinal cord, cervical area. So that they also can result in this. And you can have patient who is on, anticoagulants. You can, pituitary apoplexy. So all these causes could lead to subarachnoid bleed. So this will come as a differential. And what are the classical symptoms? Classical. This was completely a non-classical case.
Worst headache of the life, that is thunderclap headache.
Thunderclap headache. That's a specific term. Yeah.
Onset within seconds. Onset of second, and associated with a knuckle rigidity and vomiting, giddiness.
Nausea, vomiting, photophobia, giddiness, isn't it? These are the classical things. Actually, there is no difference in terms of symptomatology between ischemic and hemorrhagic stroke. So these features, if they are there, they will indicate that it is a subarachnoid hemorrhage. It could be an aneurysmal bleed. So that, and what is the, if you can outline the principles of management, just the points to save the brain, to prevent any delayed or secondary injury.
Initial
Euvolemia.
And
maintaining the normocapnia and normothermia and and
Glycemia.
good oxygenation, sir, and good no acidosis.
Temperature control.
Adequate pain
Temperature
relief.
control and targeting a hematocrit of more than 36 or more than 8 grams per deciliter of
Sugar control, euglycemia.
Glycemia.
So what is the double H therapy? If you can tell the viewers.
hypovolemia and induced hypertension, sir.
Induced
Hemodynamic augmentation.
So I think, Dr. Raymond, we have more or less finished it. And I saw Dr. Venkat Kola, so the man behind the show. So,
Sir, thank you. It is always a pleasure to have you on board. And Raymond always been the same dynamic, young, enthusiastic teacher who always loves in that evaluation and teaching students and more on to the practical aspects. Thank you, Raymond and Rajesh, sir, for that. And Dr. Sasidhar, you are all around?
Thank you, Venkat.
Yes, sir.
thank you.
Please go ahead.
Thank you, sir. Thank you, Rajesh sir and Raymond sir, for imparting all the students on SAH concepts and treatment aspect. So,
Thank you to
thank-
Uday and Shilpa also for
Thank
putting
you.
up with us.
Absolutely.
Yeah.
For
they have
bearing
answered very well.
for bearing with us, and thankful to Venkat for exposing me to what great work he's doing in Masterclass Critical Care Medicine. So thank you very much.
So this classes has been on for the last almost 9 months or so, sir. So this has been a part across the India where all the institutional students, I request Dr. Raymond and you also, your students can participate as a part of the examinee, so
Sure.
that the next batch examiners can take the examine. So that the idea is the students from the institution get exposure to the other format of the teacher, so that they will understand the different way the examiners think across the globe.
Absolutely.
And so this is a way where we see a few hundreds of students joining in the beginning, but in a day or two, we see some thousands of participants in viewing it. That means it's not only limited to the just critical care. We see many medicine postgraduates, pulmo, and anesthesiology postgraduates looking into it. And it's basically a practical based exam based pattern where it is extensively goes as. And I was actually fortunate and thankful that all the examiners, senior seasoned examiners, in the two category, one is in the legendary senior category and the other one, like all of us who are into the learning process, are a part of it. And this has been a phenomenal journey across the last 9 months or so, sir. Thank you for complimenting the team, sir.
Thank
And
you.
Dr. Sasidhar being coordinating this for almost last 9
Yeah.
months.
Thank you, Dr. Shashidhar.
Thank you, sir.
Thank you,
Thank you
Raymond.
for your time.
Thank
and,
you both, Silpa
Thank
and
you so
Uday.
much.
Thank you, sir. Thank you.
We conclude the
We'll
session.
conclude.